Hello, everyone. This is Henry Perry, and I'm so pleased today to be able to share with you my dear long-term friend, Tom Davis, who is one of my global health heroes. I don't have many. He's one of them. And Tom has been a passionate advocate for community health, for engaging communities, and for saving the lives of mothers and children in a variety of different organizations. He's had an extraordinary career, and his leadership has led to some of the best child survival programs that have ever been implemented, in my view. And he's had an enormous influence in a number of different organizations. So, Tom, it's great to have you here. And the purpose of our discussion today primarily is to talk about care groups. And Tom has been one of the great advocates that has led to the extension and expansion and the use of care groups. So, Tom, thank you for coming and share a little bit about your career, and then we'll move into care groups.
Thank you so much, Henry, and welcome everyone. It's great to have this chance to talk with you today. So I'm a global health professional. I've mainly worked in social behavior change, but also in integrated primary health care. Henry has been my mentor all the way along and did quite a bit of training with me. So now you're getting some training from him. That's great. I started out in Haiti. Back in the 1980s, actually, coordinating a vaccination program in the southern third of Haiti. Then I helped develop a national community health worker training program and training for their supervisors in primary health care in the Dominican Republic. I did a lot of consultancies with about 30 organizations in about as many countries. And then I moved into some chief program officer roles with a number of organizations where I was over all sectors. So really started thinking about how to apply this approach actually not only to health and nutrition and WASH, but beyond that, you'll see. And now I'm with Gavi. I'm their senior manager for demand and community engagement. I'm like the sole demand specialist within Gavi, if you can believe that. And I've really enjoyed that work as well. And we're actually talking about how to scale up care groups through Gavi as well.
Great. Well, I want to also emphasize to our listeners here that you also, among many other organizations you worked with, Andean Rural Healthcare, which is now Cure Americas Global, and we're very proud of that fact. And could you just say a word about your experience with that and how that was helpful in building your career?
Sure. And I'll talk a little bit more about kind of how that fed into how I've used the principles of CBIO a bit later. But I first got involved by evaluating one of their child survival projects. It was some communities, Malco Rancho, Sipe, still remember the names, down below Cochabamba. And we saw, at least in one area, this stair-stepping down of child deaths. And that really galvanized me. I actually started becoming a results volunteer doing advocacy work and took some of the graphs from that, showing the stairs stepping down, meeting with very conservative members of Congress, convincing them to support child survival. And so really, Cure Americas, Andean Rural Healthcare's work in Bolivia helped me to make the case that this really works. It's something we can do, and we can do it at low cost to end child deaths.
Great. Thank you. Well, Tom, tell us about care groups and tell us how you got involved with them and what convinced you that they were powerful.
Sure. So the care group approach is a dual cadre community health worker system. You have a paid community health worker who's the care group promoter, and they work with somewhere between 2 and 9 care groups. The care group has about 12 care group volunteers in each one, and those volunteers work less than 8 hours per week. So this care group promoter trains these volunteers in the care groups about every 2 weeks on how to promote 1 or 2 health and nutrition behaviors. They use things like flip charts, stories, songs, other methods, and teach them to use those same methods and tools to then take out and promote those with the caregivers that they work with. So following each of those meetings, the care group volunteer reaches out to about 12 caregivers, often mothers, but fathers when they can reach them as well, to promote the behaviors. The caregivers in their charge are called Neighbor Women's Group or the Neighbor Circle. and the volunteers meet with them through a combination of both home visits and neighborhood meetings that often last about 1 to 2 hours each. The care groups are really different from other women's groups in a number of ways, but one way is that the members themselves choose the volunteer who will serve them. So that means they're picking someone they want in their house, they trust, they like, and that really helps to boost behavior change. I think that's one of the secret sauces of this approach.
Great. Well, tell us about how you first learned about care groups and your experience in Mozambique, seeing one of the early care group projects. That was galvanizing for you, I think.
Definitely. So I'm a co-pioneer of this approach, and I learned it back in 1997 from World Relief when I was supporting Food for the Hungry, and we were at midterm of a large food insecurity program there, food security program. And we heard that World Relief had this method that they were trying out, an approach. So I got training for them. We did the training of our staff in Mozambique, and that led to a successive project in Mozambique with it. And then the largest deployment of the approach to date probably was in Mozambique, in Sofala province, where we reached a population of about 1.1 million people in the food security program. We saw a 25% reduction in stunting, 50% reduction in severe stunting. And it would just blew me away, the sort of results we're seeing from this in behavior change and in outcomes like underweight, wasting, stunting. Now, since that time, I've helped a lot of different organizations to adopt and scale their approach, such as Food for the Hungry, Cure Americas, as I mentioned, Feed the Children, World Vision, and now Gavi. And I've also adapted it and said, wait a minute, this works in health, nutrition, and WASH. Maybe it works in other sectors. So we tested it and began using it in child protection, early child education, even maternal mental health and gender, and had excellent results there as well. So I learned about CBIO before I learned about the care group approach. And I built a number of features into the care group approach based on those CBIO experiences. For example, in Mozambique, we did a retrospective mortality study at the beginning of a large child survival project there using care groups. And that helped us decide what are the ages at which children are dying and from which diseases. And based on that, we started working a lot more with newborns. And we even added on a sector to our work, which was WASH, given the high percentage of deaths we're seeing around diarrhea. Now, like CBIO, care groups require an identification of all the households you plan to serve. So they're both census-based, and they're both very equity-focused. No one gets left behind. That's really one reason that Gavi is so interested in this approach now. I consider it more of a push approach rather than a pull one, in that you visit people who don't make it to your meeting or that don't come to the health facility. Those primary caregivers, usually mothers in the poorest households, often don't attend important community meetings because they have more children, they have controlling husbands, they lack money for means of transport and other reasons. So we need to push services out to them. CBIO does that, and care groups do that. Also, like CBIO, child and maternal deaths, pregnancies, other key events are monitored. And with care groups, those are identified by the volunteers and then reported up. And that gave us the sort of data, for example, that we could use for advocacy. That data also would pull it together and occasionally say, okay, let's look at all of the verbal autopsy data we have and put it all together and meet with our promoters and figure out what do we need to do about this. So, for example, we used verbal autopsy data in Mozambique, and we found that a lot of these children that were dying, their caregivers said, I didn't know the child was even that sick until suddenly the child was extremely sick, and then they couldn't do anything with them at the clinic. So we realized that knowledge of child danger signs during illness was a huge problem. Kids were really lethargic. They couldn't wake them up, and the mother says, oh, the child just wants to sleep. And it's like, no, they're seriously ill. So we'd use that data from verbal autopsies and from the data system to change course. And that's part of CBIO.
Great. I'd like to refer to care groups as CBIO Lite, Lite.
Yeah.
It's much easier to implement. You don't have to make a map, and you don't have to enroll everybody in a formal census, and you can start very quickly with this. And you can even operate it without the complicated health information system that has so much written material, just with women reporting births and deaths verbally. Many of these women can't read and write anyway. So just by reporting vital events verbally up to a care group supervisor who can record that is a great benefit too. Well,
Exactly.
Tom, um, tell us about some of the achievements that you have seen with care groups, and why you continue to be so passionate about this as an important approach for saving lives of mothers and children.
Yeah, well, my main mission in life has been around reducing deaths of of women and children, child survival. And the 2015 Global Health Science and Practice paper that we put out really summarized that well, what we're seeing with this. For example, that 26 to 48% reduction in the under five mortality rate. I believe the average was about 32% with a very low cost per life saved. So that alone says a lot. But then if we look kind of by sectors, that large Mozambique project I mentioned found a 37% reduction in underweight. And when food supplements were added to it, this was in Burundi and a big food security project, CRS, Food for the Hungry, and numbers were involved. But they added food supplements to the care groups and a little bit of health system strengthening and did a cluster randomized control trial, very high quality study. They saw a 51% reduction in child wasting. I haven't seen anything like that anywhere. Also, when I was working with World Vision, we applied this for child protection. We wrote up child protection care group lesson plans, and it focused on reducing harsh punishment of children in Ghana. I was working with Bill Forbes at World Vision, who's a great guy. We found that caregivers were 28 percentage points less likely to use physical or psychological aggression against a child in the care group project compared to other areas where they weren't using it. Maternal mental health. That was another thing I started wondering. This is a problem that affects demand, affects behavior change. So Food for the Hungry actually took the problem management plus WHO model, put it into care group lessons, and saw a 94% reduction in maternal depression within 2 years. We saw a similar reduction in depression using care groups for maternal depression in Uganda in a study we did with Columbia University. WASH has often been part of care groups in the past, but when we tested it for reducing like E. coli in drinking water in Ghana, we saw a 75% reduction in E. coli in drinking water, where we promoted point of use water purification with tablets via care groups there. And most recently, Phil Moses and I did a review in 2022, just last year. We compared the results from 13 care group projects to 15 projects that did not use care groups, but use other community health worker SBC type approaches. And in that, we found that the use of the care group approach resulted in large improvements in full immunization and 21, 13, and 9 percentage point better indicator gap closure for tetanus toxoid, DPT1, and measles vaccination coverage when we looked at care groups versus non-care groups. And for Gavi, of course, that's huge. DTP1 is all about zero-dose children, those children who never get any vaccines, and we could show that, yes, this actually helps quite a bit with that. In that same study, we found like much better improvements in exclusive breastfeeding, complementary feeding, vitamin A supplementation, and underweight. And lastly, sometimes people ask, well, yeah, you did all this, but did it sustain? And there were 2 sustainability studies done on care groups. I believe at least one is in the published literature, one's in the gray literature. They both found that care group volunteers still visited caregivers, and those final level indicator achievements were maintained or bettered 2 years after the end of projects or more. Since you never pay the volunteers, and there's some real intrinsic motivation they have for doing the work, that's where you can actually sustain this work after you achieve it.
That's a very powerful list of achievements. And one of the many benefits of care groups is that it lends itself to easy monitoring and evaluation, particularly with household surveys to measure the results of the approach. So it's great to have all this data that affirms the value of this. Tom, can you tell us a little bit about the challenges you faced? This any new innovation has pushback of all kinds, and
Yeah.
there certainly have been difficulties in getting this going. So, what would you say in the beginning were some of the big challenges, and what are some of the challenges now trying to expand this approach?
Yeah, it's interesting that some of the challenges early on are still a bit of a challenge. Government adoption of this approach is still quite low. I know that Malawi is one place where the Ministry of Health has picked up this approach and mainly applied it in nutrition nationally. But aside from that, I don't know of a Ministry of Health that has picked it up. I still remember, I think you were with me, Henry. We visited this district Ministry of Health director at the final evaluation of the big care group project in Mozambique. And we talked about, are you going to use this approach in the future? And they said, yeah, I'm not sure because whether we could adopt the approach, despite the results you show, I really doubt that the Ministry of Health would do a job as a faith-based organization or a civil society organization in working with volunteers. He just didn't think they would be good at that. By the way, Gavi is actually aiming to change this. We have an RFP coming out soon that will support CSOs to work with governments to scale the care group approach in zero dose areas of Gavi supported countries. So if some of your listeners are interested in doing that, you'll see that on the Gavi website eventually. And then also, I think you remember, Henry, that Jennifer Weiss and colleagues, they did a study in Burundi and said, let's compare a CSO, Concern Worldwide, doing the approach right next to the Ministry of Health running the approach. You know, can the Ministry of Health get as good of results? And lo and behold, they did. Very similar results. So it's not that the Ministry of Health can't do it, but they often question whether they can do it. And frankly, I think that CSOs should be the ones leading on this, and that there should be some subcontracting to them to make it happen. They have those deep connections. They're often the ones that have really good connections to community health. It needs to be done together with the Ministry of Health, but CSOs and INGOs, NGOs can be part of it. Another problem, I was thinking back to the application in it was in Asia. I'll remember the country soon, but there's disbelief that volunteers will do the work without being paid. Oh, it was Cambodia and World Relief. And at first they were trying to introduce us there. And a lot of their staff and other people were like, nah, that worked in Mozambique. It absolutely won't work here. You won't get that sort of volunteerism. We have to pay people. But they had some of their best results from the care group model, World Relief did in Cambodia, where they did it. And I think we seriously underestimate this drive towards volunteerism and what volunteers can get out of the work, things like respect. I evaluated one care group project that tried to pay the care group volunteers for each lesson taught. It was like $2 per lesson, totally fell apart. And when we looked at why, partly it's like asking a friend, hey, will you take me to the airport? I'll pay you 50 cents. It's like, no, I'll do it as a friend. I'll do it to help you. But if you're going to pay me, that's not near enough. And that's what happened there. And suddenly other women were saying, well, you're paying this woman. Why aren't you paying us to come to the meeting? Jealousies. It just absolutely didn't work. Meanwhile, in Mozambique, we had volunteers that were there for 4.5 years. And when we did a survey of all the volunteers, about 200 of them, they said the reason we do this is we're respected more by other women, by our husbands, by the community leaders, by the health facility workers as well. So that respect is hard to get from other people. And that some of them ended up moving into even government positions and that sort of thing. Lastly, at the global level, there's been some pushback from some corners of global health about using any volunteers. And first of all, we agree that working volunteers more than about 8 hours a week can be exploitative. However, when you're paying more community health workers and having them work with these low intensity volunteers that only do less than 8 hours a week, as we do in the care group approach, I consider this a middle way, these dual cadre systems, and that's what we need to scale. Let's not totally rule out a role for volunteers and realize this can be a pathway to getting a good paid community health worker job, but let's use both of them.
Right. Terrific. Well, thanks. What advice would you give to any individuals or groups that are thinking about beginning a care group program?
Sure. Well, and part of my recommendations on this come from some work that we did in the core group. It was the SBC working group, and we looked at let's compare projects that have the best results on these. We call them powerful to change behaviors like antenatal care, hand washing with soap, exclusive breastfeeding, where we knew we got a lot of bang for the buck. And they found a number of things from that. One is organizations that use systematic home visitation, CBIO, or that use the care group approach, which has systematic home visitation. They are the ones that seem to have the best results. But a second was that they had robust formative research methods that they used. And I think those should be used with care groups and with a lot of other things, frankly. One is some barrier analysis methodology. You can look that up on Wikipedia. It's got all the resources. I helped develop that many years ago, but now there are probably 30 different organizations using it. Similar to that, the Behavioral and Social Drivers Survey for vaccination that the WHO, UNICEF, and Gavi Alliance partners put together. These delve into what are the drivers and determinants of the different behaviors you promote. And then along with that, another formative research tool is positive deviance inquiry. So like in Mozambique, before the big care group project, we compared who are the people that have well-nourished kids to those caregivers who have poorly, basically malnourished kids. What's different and what they feed their child, how they seek care, what they do for them in the home. And that also then helped us to know what to put in terms of activities and messaging to assure that we're addressing the most common behavioral determinants of the behaviors you're focusing on and the most common kind of drivers of the outcome you're looking at. Like in Mozambique, we saw parents that use point of use water purification for the water they gave to their children were much less likely to have a malnourished child. So we're like, let's put in a wash component. Another is just follow the care group criteria. If you look at the caregroupinfo.org website, there's a whole section that talks about these criteria. These are parameters such as the maximum number of members in each care group, how often they should be visited. They're really important and they help assure success and also helps prevent organizations saying, oh, we're using care groups and there are 40 members in our group and we visit them once every 2 months. It's like, that is not a care group. Let's not mix that data in with a very successful approach we already have. As I mentioned, these dual cadre community health worker systems, paying community health workers who are the promoters and paying a lot more community health workers, but not paying volunteers, but using volunteers that work less than 8 hours a week. I believe we need both, and we need to have a strong voice to keep this room for volunteerism, which can do so much good. And it's part of every high-income country. Every high-income country has volunteers. There's a drive for people to help others out. Faith organizations have known this for years. Let's not just say, no, we absolutely can't use anyone's time unless we're paying for it. And lastly, and this is something you really helped me to learn, Henry, was tracking your cost per outcome, things like cost per life saved, cost per DALY, cost per case of malnutrition averted, cost per additional child immunized. Those sort of metrics can make the case for the effectiveness of the approach. And we really need to be benchmarking against cost effectiveness because there are things coming out all the time. I remember one thing I saw where they're using community video and producing it. And then when I really dug into the details, it was so much more costly per outcome than anything else. And it's like, well, that's really interesting and innovative. But if I'm spending 10 times more for the same outcome, no, not interested. So we need to benchmark against cost effectiveness, I think.
Great. Well, Tom, thank you so much. You yourself in your career and your leadership have helped all of us to realize, and I've been saying this for some time as well, that our greatest resource in global health are the people themselves. And we're
Definitely.
still just at the beginning stage of learning how to work with communities to help them improve their health. And ministries of health particularly are inept at this kind of activity. And I remember Peter Ernst, who is the founder of the care group approach, he told me one time, he said he thought every district of a Ministry of Health program should have at least one person in charge of working on relations with communities, but those positions don't exist. So
Yes.
we can all hope at some point that the lessons that have been learned through the care group approach and CBIO can be a help as ministries of health gradually learn better how to work with communities and to mobilize the volunteerism and the deep concern that people have for helping each other. So, Tom, thank you so much. Any final comment?
Yeah, I was just thinking that last comment you made. Eric Serio published this great paper. I can't remember who all the co-authors were, but it was Melanie Morrow was one talking about kind of expanding the building blocks, the WHO building blocks. And part of that was we cannot forget all the good that is done by CSOs, community groups, religious leaders, and volunteers. And this is something we cannot let go of and let it just become it's health services, it's at the facility, and that's the end of it. Because so much of what we want to change, like exclusive breastfeeding, it has got to happen at the household level. And that is going to be done by outreach with models and approaches like this, and not just by health facility staff. And so thank you for being a huge champion of communities, Henry. And I hope the people listening to this will also consider themselves champions of this as we pass this torch on to you to move forward with it.
Great. Okay, Tom. Well, thanks so much once again. So long.
My pleasure.